Hi, everybody. Welcome to SimiTree's webinar. We're really glad you guys are here. We're going to give everybody just a few minutes to enter the room, and then we're going to get started here. We've got a great presentation for you today. As everybody's getting in and getting connected, if you have any questions during the presentation, please don't hesitate to put your questions in the Q&A. I will be sharing the handout in the chat as we get going here. So look for that and you'll be able to click on that link and access the handout for the presentation. I'm Missy Gilliland, the Director of Learning and Development here at SimiTree. We're very glad that you could join us today for our webinar on how to win the Medicare Advantage market. We're joined by some wonderful experts, Rob and Jonathan. They're going to walk you through this presentation. If you have any questions, please don't hesitate to put them in the Q&A. If we have time at the end, we will answer them live. And if we run out of time, we'll answer them through email. I will be putting the handout into the chat for you, so look for that here in just a moment. With that, I'm going to turn it over to Jonathan to get us started.
Hey, thank you, Missy. So I'm Jonathan Dickinson with SimiTree as a senior manager. I've been in home health hospice world for about 11 years, predominantly most of that as a director of finance and operations and overseeing the revenue cycle. So really excited to talk to you today about the Medicare market, what's changing, how we can do better as an agency and as really home health hospice together. And let Rob Simione introduce himself, and then he's going to get us started.
Thank you, Jonathan. Thank you, Missy. Excited to be here to talk to you all today. My name is Rob Simione. I'm a principal at SimiTree. I oversee our consulting team. I've been in the industry going on my 16th year. Worked with many home health and hospice organizations all across the country in interim CFO, interim finance director roles. So I've been at the forefront of some of these negotiations and working through some of the challenges that agencies have had with Medicare Advantage. So excited to be here and talking to you all today. And as we go through, if there's any questions, please ask them away. There's always lots of questions on Medicare Advantage. I would expect, or if you want to ping Jonathan and I offline, happy to help in any way. So let's get started and talk a little bit about what are we doing here today and what are we looking at? Number one, we know from the standpoint that Medicare Advantage landscape is changing. What we're seeing is that home health, obviously has been more and more of a penetration to the home health market. On the flip side, what we've seen also is the VBID model in the hospice carve out the Medicare Advantage carve out for hospice. So again, there's a lot of challenges coming for both sides of the equation. Some home health kind of current, hospice is probably a little bit down the road, although some of you probably do have some Medicare Advantage contracts. Now, we'll talk a little bit today about learning and building those relationships with the Medicare Advantage payers. And really talking about your value prop. How do you build that value prop? How do you present them with data? How do you have those negotiations and go to the table with them? What are some of the strategies that we see that can be very beneficial? And then also, how to set up your organization from a success standpoint with Medicare Advantage, right? We know it's there. We know we're going to have to contract with them. We know there's complexity to different parts of the organization from a back office standpoint, all the way from setup, all the way to executing, verification, authorization, all the way through to billing on that side of it. So we'll talk a little bit about that today. So again, really want to focus in on how to adapt in this changing world of more and more Medicare Advantage. So you were hoping I'd get on the phone today or get on the webinar and tell you the Medicare Advantage is slowing down and will be non-existent in the next 20 years. That is not what this call is going to be about. So I hope you're not disappointed in it, but I promise we'll have some good strategies. Again, the enrollment has been growing and growing. What they're saying now is about almost 7 to 8 out of 10 Medicare eligible individuals are enrolling in Medicare Advantage. Again, tremendous amount of growth on this. We saw about an 8% growth in terms of enrollees from 2021 to 2022. What we're seeing now is Medicare Advantage on average compromises about 26% of the home health agency's revenue and 28% of the visits. And that's just the median. There are other markets where you're seeing closer to about 50% penetration and growth of Medicare Advantage, making up 50% of your payer mix. So again, more and more it's growing and growing. Why is it growing? Well, I'm a finance person, so I can tell you why it's growing. It's less expensive for the enrollee, right? So what we're seeing is that there's savings of about $1,640 and a member satisfaction or beneficiary satisfaction of about 98%. Again, the satisfaction, I don't know if it's because of the actual services. My tendency is that because it's less money, people are happy about it. Because what I do hear is a lot of times, some of the services that they would typically be available are not available under a Medicare Advantage plan. So again, some of the challenges that are going on there from that standpoint. For the year, so that's for Medicare in total. For hospice, what we've seen is and again, home health being part of the Medicare Advantage benefit. For hospice, what we've seen is the VBID model. So the VBID model really was to carve out the hospice services and start applying and piloting it for certain MA plans. So in 2023, we have about 52 plans participating in the hospice, which would cover about 9.3 million enrollees that are participating in the hospice carve out of Medicare Advantage services. So again, we're seeing more and more of it. We're seeing the VBID model grow. It's been a little stagnant the last couple of years, but we do expect that carve out potentially could increase and the pilot could end and really become part of the Medicare Advantage, be part of Medicare Advantage, which again would be a big challenge for a lot of hospice organizations out there, because currently as a hospice, you were predominantly about 90-95% traditional Medicare. So knowing some of the challenges that are going to come about, with the Medicare Advantage would be negotiating your rates, the billing, the authorization, the insurance verification, all those different pieces become more and more challenged for hospice organizations. So, don't think just because you have hospice that this isn't coming. It does seem to be picking up a little bit of momentum, and we do expect it to continue to grow. So this is the map, and this is the map I think I've shown it at least 5 times in the last 2 weeks. But it's an important map to see. Why? Because what it shows is what's going on in the Medicare Advantage world. This is from the Better Medicare Alliance 22 Medicare Advantage study. It's accumulated 2022 information to see what percentage of penetration of Medicare eligible beneficiaries are enrolled in Medicare Advantage. This map last year only had one state that was in the orange at 50%. That state was Florida. Now we have close to about 7 states in the orange right now, which means 50%, 7 states are now 50% or more Medicare Advantage, including states that have seen huge increases like Maine, Louisiana, Connecticut, Michigan, and Washington State. So we've seen these huge increases that have gone on in terms of the Medicare Advantage population. So again, continuing to see these huge increases on that side of it. And even from the standpoint of those that are in 36 to 50%, tremendous amount of growth. Those states were not 36 to 50% a year ago. So it's just going to become more common. If you're in an orange state, you know this. You know the challenges. Probably about close to 40 to 50% of your patients are now Medicare Advantage. Again, that's just going to become more and more difficult. And predominantly, most Medicare Advantage, or at least half the Medicare Advantage plans, are fee for service versus being a PDGM type rate. So, again, just some of the things to be looking at. Also on the side of it too is what plans are predominantly in the market in terms of Medicare Advantage. This data is from a study by the Kaiser Foundation. And what you'll see is United Healthcare makes up about 28% of the Medicare Advantage. Humana makes up about 18%, as being the 2 big ones, as well as Blue Cross making up about 14%, CVS, 11%, Kaiser 6%, Centene 5%, and Cigna 2%, and then all other insurers making up about 16%. So again, these are the major players in the Medicare Advantage market, which total enrollment is about for these was about 28.4 million lives. So again, really important, continuing to grow. We're seeing a shift in some of the payers that are participating. So we know it's growing, we know it's getting bigger. So now Jonathan are going to get into the the nuts and bolts of what to do. So first tip in negotiating a Medicare Advantage contract. It's not about your problem, it's about their problem, right? I've always learned this as being a CFO at a lot of organizations. They don't want to know my problems, they want to know how can I solve their problems. So really what you want to do is you want to go through this process is identifying what are some of the challenges Medicare Advantage plans are having. What are their goals? Many of them are measured compared to the HEDIS measures. So if you go online, look at some of the HEDIS measures, you'll see some overlap in some of the things that we're accountable for. Hospitalization, emergency room, visiting emergency rooms, medicine reconciliation, patient transitions, all these different aspects that we're held accountable to under value-based purchasing as a home care agency, and some of the metrics, even as hospice, as they roll out the HOPE instrument, that we're accountable for are the same as the HEDIS measures. So again, get a better understanding, be able to have that dialogue. What are they held accountable for, and where's the overlap of where I can provide some value to them, right? Because then if you be able to provide value, then you may have a seat at the table of being able to really provide information on this. So do not lead with, I just want high rates. My costs are too high. Don't complain. No one wants to hear anyone complain. Believe me, my wife and kids never want to hear me complain because it doesn't matter what I have to say at all. So, but no, definitely go in there, be prepared. Know the MA contact. So who are you working with, right? You may want to get to a higher level in your organization. Quite often, sometimes you may be dealing with someone who's just there to look up rates and negotiating the lowest rate and compared to the lowest market in the market. See what, who you can get into contact, look people up on LinkedIn, who maybe knows something about the post-acute industry there that has some familiarity with home care that you can get in contact with. And what do they say about the company? Invest in their members. So again, looking up, figuring out, developing those relationships is really, really important. Start looking at yourself as an organization. What do I bring to the table, right? Do I bring volume? Is it a certain geography? If you can look up at the Medicare claims data, which follows the same patterns as Medicare Advantage. Do I have most of the market share? If I were not to contract with me, you would have huge gaps in care. Those are the conversations you may want to have. What differentiates you from your competitors? Is your quality of services? Is it the services you provide? Do you have more diversification in different types of services where you could potentially just manage the life after the discharge from the hospital, where you can manage different areas, or even before to prevent the hospitalization from even occurring in the beginning. So really understanding that. And then, really having them understand what is the risk of you not being able to provide these services, right? So if I don't contract with Medicare Advantage plan, what's going to happen? Will they be at risk? Will they not be able to have these services? Part of this too is when you go through these contracts, Medicare Advantage contracts, figure out who do you want to contract with, and there may be some you don't want to contract with, and that's okay. The volume's there for most of your organizations. It's not a volume game. It's being smart in terms of who you're going to contract with, and who's going to provide you with those rates that are going to be able to, or rates or payment methodology, or even some of the terms in the contract that's going to be beneficial for your organization. So again, be prepared with data and information to support your negotiation. So develop that data driving your value proposition, identify what their problems are and come up with solutions and the benefits. Be innovative, look at different programs, different things you can do that may be a little bit different that they can provide to the MA plan. Understand what the payer or the community partner wants, reduce rehospitalization, timely initiation of care, preventable hospitalization. These are the words we hear from Medicare Advantage plans over and over again of what they're looking for providers to be able to do. And then also do a profitability analysis. If they're giving you rates, whether it be episodic or per visit, what are you going to be able to do to be able to manage this contract? What are your margins going to look like? Are you willing to take a little bit of a loss? Are you willing to not take a loss at all? Are you willing to break even? Do you have to make a certain amount of money? Really understand that in terms of your negotiation. So you need to know your cost per visit. You have to know your cost per visit. So the most important metric outside of gross margin is cost per visit or cost per day. You don't know your cost per visit, cost per day. First thing I want you to do is call up the accounting person in your organization after this call and find out what your cost per visit or cost per day is. So again, make sure you're looking at that piece of it and really understanding what do you need in terms of a rate to be able to maintain your business operations. Keep in mind that a lot of times too, it's much more difficult to manage a Medicare Advantage contract. So your back office functions, it's not like your fixed costs stay the same. For every one biller, every one Medicare biller, you probably need 3 or 4 Medicare Advantage billers. That's just how complicated and how complex the billing is in terms of the billing authorization and insurance verification. So some of the things with contracting too, aim for 2-year contracts, avoid any evergreen terms. Again, you want to make sure there's no automatic renewals and things of that nature because you want to be able to negotiate rates based on market changes and updates in terms of what you're paying your current staff. Know your volume of your plan referrals from your top referral sources. Again, you don't need to be everything to everyone. Having contracts with every Medicare Advantage plan isn't the way to go. Find the ones that are going to pay you what you need to be able to run your operations, right? That way, from a standpoint of getting the referral and being able to process it. You're getting paid for the quality of the services you're providing. We see a lot of organizations who have, basically stopped contracting with certain plans because, again, the rates do not make sense for those organizations. Your payment options go fee for service, PDGM. We've seen some LUPA rates. We're seeing a little bit more in terms of some of the hospice value-based contracts as well, risk-adjusted value-based contracts, something worth exploring and starting that conversation. Not that it's going to happen now, but it could happen down the line. If you're unsuccessful in rates, look at some of the other areas. Less onerous authorization requirements, right? So again, we want to make sure that the authorization isn't complicated, right? If we're getting visits every 6 days, that's complicated. It's more work. It's more staff I need in my back office for my organization. Longer timely filing limits, right? Again, trying to get away from a timely filing limit that could be 90 days or 180 days. Make sure, technically, if you're Medicare Advantage, they should be following the Medicare rules. Medicare rules state 1 full year of timely filing. So if they have a problem with it, to tell them that is literally what a Medicare Advantage plan says in every one of their contracts, but somehow they change it somewhere to say, oh, we can do 180 days. No, it's a full year that you should be able to have for billing. And then again, here's just some benchmarks. A couple things that stand out. Medicare for day sales outstanding takes about 63 days to collect. Medicare Advantage, 92. That's 30 more days to collect cash. That's a challenge, right? That's going to be very challenging in terms of being able to meet payroll and meet other invoices and things that you have of that nature. The gross margin for Medicare is about 51%. Medicare Advantage, 31%. 20% lower gross margin. Gross margin is net payer revenue minus direct service cost. AR over 90 days. Medicare is about 7%. Medicare Advantage, 21%. Again, a full 14% higher in terms of AR over 90 days. And then we talked about the staffing. Insurance verification, you probably only need 1 FTE per 90 to 100 referrals for Medicare, but you need 1 FTE per 15 to 20 for Medicare Advantage. Again, authorization, you need 1 FTE per 250 census. Medicare, per billing, you need 1 FTE per $15 to $20 million per year. Medicare Advantage, $5 million per year. Again, almost you need 4 individuals, one for every 1 Medicare, 4 individuals to be able to cover some of these functions. So again, lots of challenges. It becomes very, very difficult in terms of staffing and being able to be financially successful under Medicare Advantage. I'm going to pass it over to Jonathan to talk a little bit about revenue cycle.
Yeah, thanks, Rob. And it's so key because everything in Medicare Advantage really starts at the beginning. So we're going to kind of walk our way through the revenue cycle piece, a little bit about eligibility, which we all know starts with your intake, making sure you have the right documentation information, authorization. What do we need to get authorized for? What does our contract say? What do we have the EMR built for? Orders management, billing, collections, and then all the way back through to reporting. So we make sure we're drilling into the right analytics and the numbers that have our organization focus exactly where we want to go. So kind of walking through the eligibility piece, the pieces that you're going to see on the next slide are, looking to see what kind of errors you're going to have. Rob, you can go to the next slide real quick for me. And being able to say, okay, what do we have to have for lack of clarity and eligibility of our benefit limitations? So what is being set up in your intake team? Making sure that they understand this payer is associated to this payer build we have in the system. You could have 4 different Blue Cross Blue Shield builds or 4 different Humana builds. Did they pick the right one? Do we have the right information for the payer that we want to have so we know what authorizations are needed, so we know what's specifically there? The authorizations as we go forward is, are you putting that information accurately into your EMR, right? Are you using it to the fullest of its ability? Is it telling your clinicians, hey, we're out of authorization visits? Is it following up with your back-end staff and helping them support so we don't get denied for no authorizations because we went over limits or we're doing something outside that we shouldn't be doing, that we know we don't have authorizations for? Know if your payer has retro authorizations. Do they allow us to go back and appeal this and say, hey, we didn't have authorization for this initial evaluation visit, but we want to do it? Your intake team should be the most knowledgeable team about that to understand what has to take place, along with your authorization group specifically. Your utilization management is extremely key, right? You get the authorizations, you get the visits. How are you tracking it? How are you holding your clinical staff accountable to what's actually taking place? Is your EMR able to assist you in that? Are there reports that are available for you to look through so you can limit what a managed care group is going to try to deny you for, right? We've all been in billing. I hope everybody in this group has seen or been in billing or part of it, and we all want to get paid cash, but they're still in business to, as much as they can, try to deny us for what we didn't do. If we step out of line, they're going to hit us with a denial. How do we appeal it? What do we need to do? Know what your filing limits are, right? Rob mentioned earlier, we should have that 1 year because it's a Medicare Advantage plan, but sometimes you'll get on there and they'll say, well, you have 180-day limit filing, 120-day limit filing. If you can't get away from that, you need to make sure your processes are built to hit those goals, to make sure those ones jump to the top of the list. What's the percentage of your payer group that's going to be in that? I always look at payer mixes. If it's more than 10% of your total revenue, it's a key component for me, right? Hey, we got to do something to make sure this. If it's 1% of your revenue, don't spend 90% of your time chasing 1% of your revenue that would be there. Longer claims process filing, Rob mentioned that earlier. The collectability is almost 30 days longer than it would be for Medicare. And then have your billing codes built. At SimiTree, whenever we work with clients, we always look at those billing codes and say, are these updated to the contractual rates that you have? Do you have an annual review of your billing codes? Don't just assume everything's going to continue on. Did something change? Do we now need to use an S code or a T code or a G code that needs to be submitted? And then what does our appeal process look like when we want to go through it? What are we going to do? How are we going to follow up on that? So Rob, you can go to the next slide. The denials that you look through are pretty common. We've probably all seen these different denials, right? You're going to have claims not on file. And how are we looking at this? The overall piece of this slide, for the shortness of a 30-minute presentation, is do you know what your EMR is going to do and what your processes are around all of these areas and how to handle them? If I get denied for the claim not on file, where did I make my core mistake? Or did something get held up in my third-party clearinghouse and we don't review those errors? We thought it went out of the EMR, but it didn't get ever to the payer. Or we have wrong information, or there's no authorizations. Control what you can control. Figure out what exactly is within the control of the agency or the organization and say, these are pieces we should never make mistakes on. And from that point, allow everything to go to the payer and then follow up backwards, right? I always say you want to manage by exception a little bit here. You want to say, I know these things are going through smoothly. Where are my areas that I can improve and get better on? If I'm missing codes, did my clinician choose the wrong visit type? That could be the problem. Drilling down to that core level issue that would be there. You're going to have timely filing. You're going to have payer processing errors. It helps as well along the lines of that beginning negotiations and that beginning contract piece to say, hey, we want to contract with you. We want to have this under control. What can we do from a monthly, maybe at least minimum quarterly review with my Medicare Advantage contact and say, hey, I want to have meetings to understand what is being updated. Do I need to fix anything? Hey, we got a whole bunch of denials that came across. How can you help us fix these, right? We call the rep, we don't get anywhere. We need some help on a higher level of what's taking place. So the last piece about this, and again, 30 minutes trying to fit all this in, is really that billing, collections, and cash postings that we would look through. Rob, that last slide real quick. This is one where, you want to look at your billing, collections, and cash postings and say, what can we centralize? We believe firmly your billing should be centralized. You don't want to have that specifically within each location, but within that centralized billing process, it is a best practice to have some specificity around your payers, right? If somebody really knows Aetna Medicare, Humana Medicare, and the Medicare Advantage plans, have that person focus on those because they're going to know it and cross-train them to teach others what should be done. It's really hard to hop around to 18 different payers every day and understand exactly what you should be looking for, what we should be going through. Understand the processing times and the follow-up timeframes for what you should be expecting. Hey, I know I just submitted this claim. I know I don't hear back for 14 days. It's pointless for your team to go in and touch that claim every day because you already know what the rules are. Use your team to the most efficient manner and understand what those expectations should be. Maximize the automation as much as you can, right? So we say maximize the portal utilization. You don't want to be sitting on hold for 2 hours, right? I've worked with team members who just sit on hold for 2 hours and say, hey, been a great 2-hour day, but they did nothing, right? Get them into the EMRs, get them into the portals, submitting your appeals, submitting your claims, submitting your authorizations, and having all that built as much as an automated process as you can. Again, trend towards kind of just those top denial reasons. What are we having for denials? Your electronic remittances need to be used for every payer that offers that. That will speed up your cash collections and also make your cash collections as accurate as possible, allowing we always will practice that if it doesn't match up ideally dollar for dollar on the EMR to what your cash collections say, those adjustments should be posted manually. Hey, something was off. What was off? What do we need to figure out in the system for what we have? And then understanding the terms of your contract. Rob mentioned it earlier. You want to make sure that your contract, as it gets updated, as it gets changed, you're a part of. I was part of a hospital system, and unfortunately, right, contracts changed all the time. And home health and hospice was the last one to get the answer of what happened. And we'd find out a month and a half later, no, we're not paying you this anyway anymore. Or somebody signed a $500,000 agreement that says you're going away from PDGM and now you're going to get paid fee for service. Well, we need to know that, right? We need to update our EMR. We need to update our processes. We need to maybe make a payer mix shift. Okay, well, we're going to have to shift away from something or change it to a way that we're going to do business to make sure we're profitable. KPIs are kind of like I love them. I love dashboards. I love things that you can put together to be able to show what you should do. And really some of the top things you should be looking at is your AR over 90 days. I always say, always look at that as billed and unbilled, right? Because unbilled potentially could be things that are out there that you think is going to come in cash. You don't have it. And then understand, when should I be getting my cash for those? What's my cash collection time frame? Understanding your day sales outstanding, being able to process these pieces and putting them on at least at a minimum, a monthly dashboard for your billing collections team, for your AR team, for your finance team, to understand what's happening in your business and how the shift to more Medicare Advantage plans is going to impact your AR. Hey, I need to tell my finance team this is going to happen because I'm going to have them on AR a little bit longer than we used to, and my cash is going to come in a little bit later. Once you get into your trend, you understand what's happening. But before that point, being in finance, again, that person is going to call you up and say, whoa, your AR is jumping up and nobody told me. Well, we just signed 3 new Medicare Advantage contracts, and those are going to take on average for us 90 days to get collectability on that, right? Not 35 or 60 days. It's going to take a little bit longer. Let them know what's taking place. So with that is a shotgun 30 minutes for everybody there. Sorry if we talked really fast, but any questions, Missy? I wasn't sure. I didn't pay attention if there are.
And Jonathan really does love KPIs. He was actually on vacation sending me KPI reports. That's how much he loves them.
I do.
Stop.
No, we don't have any questions in the Q&A. If anybody has any questions, we've got a couple of minutes left. So we have a question on any suggestions on how to get the contracts. How do you get the contracts?
So I'll start, Rob, and you can finish. I'm not sure exactly what you mean by how to get them, right? Like if you're part of a hospital-based system, potentially, you'd probably have to get them from somebody at the hospital who's running your contracts, or probably in legal might be a good place to start. Hey, where can I get this contract? If it's internal, I would assume somewhere you would have that, maybe your administrator or again, legal side would have that.
You can go through like a credentialing process and really reach out to the payers and understand what their credentialing process is, so to make sure you meet all their requirements from that standpoint. So typically what you can do is, basically I think most of the websites, or even go in there and figure out who your contact would be. Usually the payer has like an administrator for each region or something of that nature. And you go through the credentialing process. Obviously they want to make sure you have like all your, you are meet all their business requirements, that you could contract with them on that side of it. So it's really going through that things. You may be able to, if you're like a member of an association or something of that nature, there may be contacts on the website that say, hey, like, you're a regional administrator for United Healthcare for this counties or these groups of counties in the state is this individual. Reach out to that person. They'll kind of put you in line to start the credentialing process. Now, keep in mind, like, some payers don't contract with everyone. They've narrowed their networks down a little bit, so they see that there's a saturation of payers. You may not get that contract, but which is important. Why is important to kind of diversify your business, show your value, and things of that nature. So
that makes more sense. I thought you were asking like, where are your contracts? Yeah, my fault.
Awesome. Well, we're getting a lot more questions. We are kind of, Rob and Jonathan, do you have just a minute to answer a couple of questions? Or would it be, I think it might be better if we send these out in an email. We'll send it out to everybody, kind of address these questions. Because some of these might take a few minutes to address.
Yeah,
so
that might be best.
Yeah. So I really want to thank everybody for joining us today. If you have any other questions, shoot them in here into Q&A. We'll get a response back to you here shortly and get your questions answered. We really do appreciate you guys joining us today. As always, if you do have more specific questions, please feel free to reach out to Rob and Jonathan. Their contact information is on the screen. A recording will be sent out to you along with the handout and the answers to these questions. Within the next, with the holiday weekend, it might take a little bit longer, but usually it's about 72 hours after the webinar. So thank you again for joining SimiTree. We were glad you guys were here. Reach out with any questions, and you guys have a great day and a wonderful long weekend. Thanks, Rob and Jonathan.
You got 2 thumbs up. Awesome. That's my first time I got thumbs up on a webinar. Good day. Made my day. Thank you, everyone.
Thank you. Have a great day.